You could tell that's divine inspiration. That is providence. Bite-sized bits from George saying, do this, say this, go here. Don't be afraid.
Yeah. Yeah. That is, yeah. I love her story. Complete divine intervention to shift consciousness and how people look at this and treat this. And I just love, Karen, we just keep getting God in all our podcasts. And that's
Oh,
what I just
no.
love the most.
Is must have been she is an answer to so many prayers of people, family members suffering who have the same niggle in their intuition as nurses do. It's like, really? Like they can't even wake up? Like, is it, and you don't argue because it makes sense because everybody has inhaled their saliva. Well, maybe not everybody. I've inhaled my saliva and it's very uncomfortable. Or something goes down the wrong tube and then you picture,
Yeah.
put yourself in your and it's empathy. You picture that hard plastic tube in somebody's trachea and how uncomfortable that must be. And it's like you feel like you're doing the right thing. But where's the evidence base about it? And where is this friction in my nervous system that's telling me something's wrong? Where's that coming from? And she is the answer. And I love her term moral injury. I
Yeah.
think a lot of nurses who are going to listen to this podcast, it she pulls the rug out from underneath you. It is an immediate paradigm shift when you hear her experience, her case studies, her research, or other people's research. You can't unsee it, but she's there to catch you. She doesn't just pull out the rug. She's like, I understand. She's seen nurses have those moral injuries, that moral trauma. Like, oh my God, what have I done? It's gonna take me a little while to process this one. Like,
Yeah.
I want to, like, I have my skin's crawling right now, like going back, all of those intuitive hits, all of those people I've snowed, and yeah, I haven't worked in an ICU since 2014 or something like that. Um, but for the 20 years before that, holy moly,
You know
it's
what?
like,
We don't know what we don't know. And
no,
there's always somebody influencing change, like Polly, like Kali. Something happens, and you just really hope that everybody will jump on board with this because it seems pretty dang obvious
yeah,
of what needs to change. But people get there in their own pace, right? Like she's saying, like there's people that just can't even fathom doing it the way she's suggesting.
yeah.
And so they move a little slower. And I really hope people will jump on board.
I
Sounds amazing.
love the quote, and I'm sorry for anybody listening to this. I hate not attributing a quote, but I will say it's not mine. But it's when you've been stumbling around in the dark for so long, and I'm paraphrasing it, and the light comes on,
Yeah.
you can either look around and dwell and focus on all the damage you did stumbling along in the dark, or you can just be grateful that the light's on. And
Exactly.
for myself, I'm going to walk away from this and I'm sure I'm going to be upset about all the stumbling around in the dark. But anybody who listens to this podcast with Kali Dayton, any nurse awake and walking in the ICU, I'm sorry, I'm getting that wrong too, but Kali Dayton is revolutionizing how we care for patients on ventilators. And when you listen to this podcast, you will not be able to unsee it. And just be prepared, you might get upset about the mess that we've made, but be grateful that the light's on.
Exactly. There's a healing process, and heal it and then move on.
Yeah. Amen, sister. Enjoy. There's two kinds of podcasts that I get most excited for. One is obvious. It's just introducing nurses to evidence-based stuff they've never heard about. That it's just not in the conventional medical world. They don't have time because of their busy lives, busy families, or just lack of interest to learn about alternative, integrative, functional, like all those different kinds of medical paradigms and therapies with the evidence base and what's going on all around the globe that we maybe don't have access to or don't talk a lot about here. That's just like, why doesn't everybody know about this? That kind of, stuff. The other thing is what you do, and it's just a totally, like I like to say, blowing up the boxes that the rest of the world are still trying to think outside of, especially when a nurse goes, you know what? I'm taking this bull by the horns and I'm going to do something about it. And, because we all, like, you and I talked about a week ago or something. And I was like, I was listening to one of your podcasts and I so related to, this is just the way we do it. But there's a niggle in our intuition. And don't worry, anybody watching or listening to this, we're going to get to the meat of it pretty soon. But I know that a lot of nurses in ICU, where I worked for 20 years, can relate to. There's this niggle in your intuition, and it's like grating on your nervous system. It's like itching powder in your blood. It's just like there's something wrong here. There's something wrong here. But then you see a patient on a ventilator wake up, and the first thing they go to is their face, and it's like, oh my gosh, they're going to extubate themselves, and snow them, restrain them,
quick.
Yep. Yeah. And when I have, you just confirmed the niggle I always had. And then the more I read about your work and what you're doing, it's like, of effing course. So I would love it if you would begin this. We'll do the, LinkedIn introduction about you later and tag it on. Most importantly, I would love to know, it's like, tell them what you're going to tell them, then tell them what you told them. How did you follow? How are you the one who took your niggle as a vocation and a calling? Like, where'd you start? How did you get there? How did you incorporate that into your own nursing practice? And then how did you bring it to the world, really, and an expanding world in your nursing career and the trainings you're doing, and how you are a one woman transformer pioneer of ICU ventilation practices. So just tell us about, spitball and tell us about your career trajectory and how you got here with us today, basically.
Yeah, this is what I call an ICU revolution, and it started well before me. But my personal journey in this started in 2012. I was interviewing for my first job as a nurse in a hospital. I'd worked at other places. I'd done missionary work and other things in the 3 years that I'd had my license, but this was my first job in a hospital. So very green, very novice, and I was interviewing straight into an ICU. It was a high acuity medical surgical ICU in Salt Lake City, Utah. And the nurse manager brought me into her office and said, "Hi, come on in, sit down." And almost immediately after asked me point blank, "Would you be willing to walk intubated patients?" And I was so new that I didn't exactly know why she was asking that, what that meant. And I was like, "I'll do whatever you teach me to do."
Probably good that you were new.
They hired a lot of new grads there intentionally so that they started with a blank canvas. But she said that that's standard. And again, I didn't really know exactly why that was a big deal. And I started working there, and no one made a big deal out of the fact that almost every single patient was awake right after intubation. Obviously, they would be sedated for the procedure of intubation, those induction meds. But as soon as those meds wore off, they'd be awake, writing on a clipboard. And we'd walk them through this process of acclimating to the endotracheal tube. And an hour later, they'd be just hanging out in bed on their cell phones, typing on their computers, sitting in a chair, walking around the unit. And so because no one made a big deal out of this and everything was new to me, I just took it in stride. It made sense to me. Of course, my patients are human, so they're going to be awake during the day, asleep at night, communicating their needs, mobile, going to the bathroom and the toilet in the corner of the room. We're just going to scoot the ventilator over to make that happen. I never questioned it. And so I did that for a few years, thinking that that was normal, not a big deal. I loved it. I had such sacred experiences with my patients. Sorry, I keep hitting stuff. I had such sacred experiences with my patients. It was just amazing. But I loved everything about critical care. So I just wrap this up into it as far as, of course, I'm going to be talking to my patients about goals of care while they're in these very critical, vulnerable, and potentially final moments of their lives. Of course, I'm going to be helping facilitate the goodbyes, at the end of their lives. Of course, they're going to be kissing their loved ones after we extubate them. Of course, we're going to be talking about why they're fighting to live. Of course, we're going to be, celebrating every milestone while they're intubated and, counting every step that they take. Like it was just unquestioned in my mind. So after a few years, I know I was young. I was about 24 at the time, single. I want to explore the world. So I became a travel nurse. And no one really told me about what the outside world was like.
Hmm.
My mentor, Polly Bailey, she's a nurse practitioner there. She actually started that process of care. I didn't understand her history or why she was such a big deal. But she's mentioned, it's going to be different elsewhere. And that's all I knew. So when I went into a new ICU, my very first shift, I walked in there. It was day shift, but all the lights were still down. Every single patient was in bed. It was so quiet. It was eerie. And I got my patient assignment. Then I had an orienting nurse with me, and one of my patients was intubated, and I wanted to continue my routine. As a nurse, we have
Yeah.
our routines. You've got your brain lets it out. You've got your routine. You're gonna do what you know. Well, what I knew was talk to my patient, have my patient communicate back to me, do a full neuro exam, probably get them into the chair to wait for physical therapy to come. But I couldn't do any of that because they were laying there motionless with no response because they were sedated. And there was nothing about their acuity or their diagnosis that helped me understand why they had this sedative going. There were certain reasons in my first ICU, like status epilepticus. If they had the severest of ARDS in which they couldn't oxygenate with movement, boom, they'd be sedated, right? Otherwise, I mean, I walked people in a PEEP of 18 and 100% with vasopressors. So I was looking for the reason as to why the sedative was going and I couldn't identify it. So I asked the nurse that was with me, orienting me, hey, can I get sedation off and get him up? And she responded with such shock and horror and said, well, no, they're intubated, which shocked me.
Oh
And I
my
said,
gosh, this is
I know
such
they're
a good
intubated.
story.
And, I was just so naive, right? Like, I really only had about 2 years under my belt. And I was like, oh, I know they're intubated, but why are they sedated? Just so innocently, right? And she got more concerned and said, because they're intubated, which I'm sure was really scary to
What
her,
planet
right?
are you from?
What, I don't know. Do you have ICU experience? Like, what are you doing being a travel nurse just showing up and asking these stupid questions, right? And I was like, I know they're intubated, but why are they sedated? And we'd go in circles. And I just kind of shut up. I was like, well, clearly she doesn't know what I'm talking about. And I don't really know what she's talking about, but I'm new here. I'm the guest. When in Rome, you do what everyone else does. Um, and so I just did it. And I had a lot of assumptions that I think we make as far as I had questions, but I didn't feel comfortable asking them.
Hmm.
Everyone else accepted this as normal. And if it's normal, it must be benign. It must be safe. It must be okay. There must be a reason for it. And I just wanted to fit in, right?
Sure.
So they're joking about it, they're laughing about it, calling it like we're just gonna knock him out and make him sleep. And I'm like, yeah, sleep. Okay. And I just assumed, yeah, maybe it is sleep, like maybe it is okay to just not know what's going on. So I was a victim to the myths and the misinformation out there because I was never taught why we did what we did in my first ICU. No one sat me down and said, hey, Kaylee, this is really unique what we're doing here. And other places, they'll put them in medically induced comas automatically. And here are the risks of that. And here's what the benefits of what we do here. Nothing. I was never taught the why. And unfortunately, I didn't investigate the research. Nursing is an evidence-based profession.
Hmm.
We should know why we do what we do. And instead of digging into it, I just went with the flow. So for the next few years, as I traveled to many ICUs throughout the USA,
Yeah.
I continued to hang that sedation, titrate it up. About my, I want to say like my third ICU that I hit, this is about 2016. Um, the charge nurse in this new unit said, hey, we do this really annoying thing here about 5 in the morning. You have to turn sedation off. And when you start to see them move around and thrash, that's how you know that they can't tolerate the ventilator and that they're not ready yet. And you just turn sedation back on. And then under here, chart failed awakening trial. And I thought that's weird. Like again, why are we doing this? And the words they can't tolerate the ventilator was really confusing to me because I thought I know I've seen hundreds, if not more, of patients tolerate the ventilator. I don't know why this patient can't tolerate the ventilator. I don't know what's going on. I can't do a full neuro exam, really. Like I can't communicate with them. I don't know why they're behaving this
Maybe
way.
they only tolerate it in Salt Lake.
Well, yeah, we'll get to that, I because I thought like, well, maybe these patients are different, because again, I just think back to my perspective is pretty narrow. And so I just did the things, just did what I was told, right? After doing that for a few years, I went back to my first ICU. And I had been told things because I tried to explain, where I came from, patients were just awake. They were just hanging out. We walked them around and I got responses like, even from physicians, do you follow them with an intubation cart? And that was confusing to me because we never lost a tube while someone was mobilizing. And I said, no, we just don't pull it out. We just protect it while they walk, um, or sit or stand or whatever they did. Um, and questions like, well, weren't they coughing and gagging all the time? And I was like, no, I mean, sometimes, especially when they first came out of intubation, but then they got used to it and it was fine. I couldn't explain the difference, right? And so I thought, meh, maybe they're right. And people would say, your patients must not have been sick. That must have been an LTAC. Those were different patients. I'm like, yeah, maybe. So when I went back to this ICU, now with, a few more years under my belt, and having been to lots of different specialties of ICUs, I was like, no, hold on. There's a bone marrow transplant unit in this hospital. So we're getting patients in multi-organ failure that have been rotting in these oncology floors for a long time and they're really sick. There's not a lot to work with by the time they come to us with septic shock, ARDS, pulmonary edema on top of it, and, 3 different infections. And they're objectively very sick. These are sicker than even the trauma patients that I treated. They have a lot more going on.
Mhm.
And yet they're up sitting at the side of the bed, standing walking to the chair, sometimes walking in the hallways a lot of the time. Why is this so different? We get a lot of patients from the shelters. We have a drug park across the road. We have detox unit, psych unit in the hospital. We get patients from all over the region for ARDS. It was informally an ARDS unit.
Hmm.
And yet these patients were treated so differently. Most of them were successfully extubated and walked out the doors, but I'd seen a lot of tracheostomies and a lot of pig tubes in other units. And I thought, is that because they were different or because we treated them differently? Sorry, hold on just a second.
Take your time.
Love that.
I have an on-air button.
Go on.
Sorry, I have an on-air button outside my office, and I had that on, and I'm like, they're still trying to get in. Poor kids.
And summer.
So anyways, I'm like, okay, objectively, these are very sick patients. I felt like I started to realize, was I gaslit? Was I led to believe something that wasn't true? But what is the real deal? And so as I looked into and at that point, so was I led to believe something that wasn't true? And so I was also in grad school at the time, getting my doctorate in acute care gerontology.
Hmm.
And I was surrounded by professors and colleagues that were very experienced in critical care medicine and in the ER that I respected a lot. And even in my classes, we'd be going through case studies and a patient comes in the ER with pneumonia and they get intubated and they were hemodynamically stable before intubation, but now they're on propofol and now we're starting vasopressors because now they're hypotensive. And I'm looking around and everyone's just nodding their heads like this is normal. And I'm asking, why are they on propofol? Why, if they're hypotensive, are we giving them propofol? And they're looking at me like I'm crazy. Well, duh. This whole thing again. And I felt like I was crazy. So that led me to finally look into the research. And by that point, it was like 2017, 2018. And there was research about this showing the risks of sedation and immobility. My own hospital, I didn't know this, but that team was the first one to publish in 2007 showing that it was safe and feasible to walk intubated patients, even with a median PF ratio of 89, which means that these lungs were very, very sick. And they were walking these patients, and the adverse event rate was less than 1%. And I'm like, well, someone could have mentioned that to me. This ICU was like pioneered what we now call the ABCDEF bundle. So it inspired a lot of the following research on early mobility in the ICU, keeping patients awake and mobile. I was working in that very first ICU and had no idea because by then it was so normal that it was what everyone did. Unfortunately, without being empowered as a nurse to know why we did it, when I
Mm.
went to a normal culture, I still fell into This is what we do because everyone does it, but in a very harmful and even lethal way. And so I really regretted that. And I thought if I had known what I'm learning now, I wouldn't have done these things. And at the same time of exploration, I serendipitously, I really feel like this is divine intervention. I was on an airplane ride and I sat next to a man. He asked what I did for a living. When I told him that I was a ICU nurse going to grad school, the color just dropped from his face. And he started to tell me about his time in the ICU. Now he was in like his mid to late 40s, seemed healthy, so I was surprised to learn that he had been in the ICU, but it could be anybody. He'd had an endoscopic procedure and had a perforated esophagus and ended up intubated, in septic shock. He said he was on the ventilator for about 3 weeks, but that's all he mentioned about the ventilator. All of the rest of it was about these, what I thought at the time were hallucinations, but now I understand them as realistic alternative graphic realities.
Realistic alternative graphic reality.
Is that
Yes,
Okay.
is that what was happening with the people who couldn't tolerate it?
most likely. So I didn't, I was still trying to piece this together. And as I'm listening to them, I say, oh, it sounds like you had ICU delirium. I knew enough to be like, oh, you were confused. Like you had these bad dreams or whatever. Like, but you were in the ICU, bro. It's fine. Like that never happened. But he really, even over 4 years later, could barely talk about what he experienced as far as having his limbs nailed to the ground in the middle of a forest while trees came crashing down on him. And demons were coming out of the sky. And there were a lot of things that he alluded to that he still couldn't talk about. And that's why I'm like, it didn't actually happen. Why are you so upset? I mean, it was a bad dream, but you're alive.
A
We did our
psychedelic,
job.
you know what I mean? Like a bad trip.
It was a bad, bad trip. And he said that recovery was really bad. I mean, we're learning how to sit, stand, walk, swallow. All those things he lost during that short period of time in the ICU was really painful and difficult. But the worst part of it was that every time he closed his eyes, he would be lost back into those alternate realities. He was right there back in that forest, trying to get away and unable to get up, which, is probably restraints, pinned down in the middle of the
Yeah.
forest. I mean, these are real, his environment he was sensing, but trying to make sense of it turned into something much more traumatic. But every
Oh my
time,
gosh. And so he was trying to stay awake to stay
yes,
out of that alternative reality. And
yes,
so he would struggle to stay awake. And it was interpreted as, oh, you're not tolerating the vent. More snow.
more. I can only imagine, right? So he was there for, over 3 weeks in that ICU, but if he'd been in a wake and walking ICU, how long? Like how long was he continually sedated and still on the ventilator because of the delirium? It's hard to know. And I didn't know enough at the time to ask him more questions, right? He mentioned that he couldn't go back to work. I obviously had terrible PTSD, but I also wondered, did he have cognitive impairments, which we know happens from these drugs and from delirium? Did he have a brain injury that made him lose his career in his 40s?
Mm.
Again, I didn't know that. And I thought this is crazy, but it's probably so rare. I had worked in 11 ICUs for 6+ years. If this was a common thing, so educated and experienced, would have known about it. We would have been talking about it at the bedside. This has to be a fluke, but I had this gnawing suspicion, like I just have to know. So I joined survivor groups on Facebook, intending to ask these survivors if they had had any kind of experience like that, but I didn't have to post about it. As soon as I was admitted into these groups, I could just scroll, and the posts were about nightmares, flashbacks, panic attacks, insomnia, not being able to like balance their checkbook, read a clock, struggling to even type out those posts. Like, is anyone else's brains broken? They didn't have the words to really articulate it, but they were describing things very similar to what this man had described. So then that led me to go into the research and be like, how common is this? Yeah, it's like 20+% of our survivors live like this for many years. It's a long-term disability called post-ICU syndrome. And then maybe think, how much of this is from what we do to them? Um, and so it just made me realize that though, patients can develop delirium from a lot of different things, this delirium is acute brain failure. It's one of the organ failures, but I never thought of it that way. I just thought it's like transient confusion. It happens in the ICU. When they get out of the ICU, it'll go away. They'll realize it was a bad dream. Because I knew that maybe they thought that we were like, I've had 911 called on me from a patient in delirium because they thought that they were kidnapped, That was someone that was not intubated. And they were able to articulate that. And I could recognize, okay, they're confused. But yeah, these patients said when I was doing awakening trials, were they coming out in absolute panic because they had delirium? Because I'd seen patients come out of intubation being like, whoa, this is tube and it's a noxious stimuli and I'm coughing and gagging, but we work them through it and they're fine. So it made me look back at it. I'm like, did I harm patients? Did I not know?
That's what
And
I've been thinking in my head this entire podcast so far. Like, oh my gosh.
and yeah, so I was obviously feeling that, right? But and then I thought that was never my intention.
Sure.
I was a victim of this gap in education. And I also felt guilty because I'm like, oh my gosh, I had worked in an awake and walking ICU. I didn't call it that at the time, but I'm like, I knew how to keep patients awake and mobile. Yes, sometimes they developed delirium, but probably not nearly as commonly. And because I saw in research up to 81% of patients develop delirium. And I'm like, no, not in my home ICU.
Mm.
It was the exception. Um, and so I just kept thinking, did I do something that I didn't realize I was doing? And my wonderful colleagues that I worked with compassionate and skilled, experienced, wonderful people that would never intentionally harm patients. They don't know that this is happening. And they don't know that we're doing what we're doing in the ICU that I'm back at, right? They thought they didn't think it was even possible to have patients awake, let alone walking. So I just felt this burden of responsibility, like I needed to disseminate this to the world. But I was in the thick of grad school and so many things were going on. And after I graduated grad school, it still haunted me. And I remember I interviewed into an ICU at my hometown. I'd been working as an NP for about 2 years and I wanted to move back to where I was from, which is Spokane, Washington. And as I was interviewing, I felt this kind of burden of responsibility. Like I couldn't just go into a normal ICU anymore. I was working as an NP in an awake and walking ICU where we were all on the same page. But if I were to go to another ICU, how do I navigate that? How do I ethically write those orders?
Yeah.
Um, and how do I bring change if the team isn't wanting to figure that out with me, right? How do I lead this as a provider, but in a new setting? So I told this group of people that I was interviewing with that if they hired me, the greatest value I could bring is to help them keep patients awake and mobile on the ventilator. And they looked at me in absolute confusion and shock and said, "You can't do that." And I said, "Well, I mean, I've done it for 7 years now. So do you mean I can't walk patients on ventilators or I can't teach your team how to do that?" And they said, "Well, what do you sedate them with?" I mean, they couldn't even imagine it. And I realized,
It's like a scotoma. Like can't even see, like
no, it
Cortez
just
is coming in with his ships and the Native Americans can't even see the ships because it's not even in their realm of, like can't even,
imagination.
yeah, can't even imagine.
It was just, yeah. And I just realized I don't, there's so much to explain here, but like I'm in the middle of an interview and like, where do I start? How do I talk about this? Um, so I just took these little, like all these experiences throughout the years. And I was driving in my car December 2019 and almost heard an audible voice, which I just feel like was God telling me start a podcast. And I didn't even listen to podcasts. I hardly knew what they
Hmm.
were. And I was like, a what?"
Can you
And
say
it
that
like came again.
louder?
Yeah, it was, start a podcast. And I was like, and I just couldn't, it was not my thought. And I was like, okay, okay. So I called my husband and I was like, I'm gonna start a podcast. And he's like, "Do you know what that is?" I'm like, "It's like audiobooks or something." And then I would wake up in the morning and have clear instruction on like what topics I was supposed to cover, how to start. I mean, I had to make a list. Survivors came out of the woodworks from these survivor groups, my colleagues. I mean, and I was with this very clear instruction. I had to do like 30 some odd episodes by the beginning of March. And this is now
That's
like
specific.
very specific. And now it's like the beginning of January 2020. And I'm like, oh my gosh, I was pregnant with my third child. I was so sick. And I still would show up to work like 5 in the morning to have a quiet room to record or barricade my closet against my toddler. And but I'm like, okay, God, I'm gonna do this, but you gotta get off my back because I'm so tired. So I'm gonna get this done and then we're just gonna call it good. And I'll probably lose my career over it, right? Because this hospital was part of a multi-organ, no, this hospital is part of a multi-hospital system, but it was the only ICU doing this. And I'd had one of my other experiences. I had been part of a meeting and kind of presented to the head of critical care to say, look at the difference in outcomes of our patients. So we compared it to another hospital, like that was like 10 miles down the
Yeah,
road.
you definitely do podcasts because everything that I'm about to ask you, you just go into like, I
Yeah.
could just sit here and
Yeah, there's a
listen.
whole
It's on the
story,
edge of
right?
my sheet. Yeah, it's great. Keep
Well,
going.
you're welcome to cut me off anytime, but
No, you're
here, so
doing
this is like,
great.
I want to say
Is,
this is like
I feel
November
like I'm
of
watching a
2000.
movie.
I know that, well, I have a whole idea, so many ideas for documentaries, but it was like November 2019. So even before that interview,
Yeah.
um, talking to this head of critical care saying, hey, and I had worked float pool in that system. So I'd been to all of their ICUs. And I'm like, I have seen firsthand the difference in care and outcomes. But we also captured it in this data showing that
Yeah.
97.5% of survivors went home from our ICU. Same patients, same level of acuity, Apache scores, same patients, right? From another hospital in the same system, only I think it was like 54% went home from the hospital after an ICU stay. And this head of critical care got very defensive and very argumentative and slamming his hands on the table and yelling at me and whatever. So it didn't go well. Um, and so here I am starting this podcast trying to share what we were doing in that ICU, and within our own system, it was not well received. And I knew I was feared that if I used the name of the hospital, I'd get shut down. So I was like, whatever. And it's not just about one ICU, it's about a process of care.
Yeah.
So I called it an awake and walking ICU, trying to capture what it was like in that ICU. Like most patients are awake and walking and they're doing as much as they can do. We're preserving their baseline. So start this podcast talking about this and really painting out the why. So interviewing survivors, and I'm learning as I go. Because I worked in that environment, but I had a lot of questions as to what are the benefits of it? What's the real harm of what I had done in my other hospitals? And what makes this work? You know, everyone comes together, but what parts are they playing? So, anyways, I cranked out these 30 some odd episodes by the beginning of March, and boom, COVID happens.
Mm.
And I'm like, well, that was a waste of time. No one's going to care about this. It's all about COVID now. And it's like God shook me by the shoulders and he's like, are you serious?
Yeah.
You've just spent so many hours researching this, developing this content, and don't you realize that, I mean, millions of people will be on ventilators and we need this now.
Yeah.
And, you know, I didn't have a lot of listeners at the time, but I'm there were people that were listening and there were people that were applying these principles and they would email me and say, hey, I did this with this patient and they got extubated and we were about to trach them. You know, just talking about how they were able to course correct or also saying, freak, you could have put a trigger warning. Because now that I see it, I can't unsee it. And it's
Yeah.
really hard for me to listen to the podcast on my way to work and then walk into work and I can see what's happening now where I was oblivious before. And so I continued, I just couldn't stop trying to investigate it. It felt like investigative journalism to me to figure out what makes this work and how do we bring this to the
That's
table. And I kept being like, just let
exactly
me
what I
come to
was
your
thinking.
hospital and show you.
It's like you introduce a little piece of data that makes the way it's always been done feel so out of integrity. You just cannot do it. It's almost like you're inseminating people with information that now they're pregnant with a different way to do it, and you can't, in good conscience, and in good conscience, with your integrity intact, continue to do what you've always been doing when you have all of this data, not just case studies, but published research that says that sounds like it was just wholly ignored
You know,
or
and
not
it's
seen or not looked for.
yeah, I mean, so let's give a quick history of critical care, right?
Yeah.
Back in the 70s and 80s, medically induced comas were not a thing. Patients were intubated and awake, walking. We have pictures from San Francisco patients, but like they were not the kind of patients we take care of now, right? Maybe they were intubated for airway protection, or, you know, we weren't able to give a lot of support. The technology wasn't there, the knowledge wasn't there. We knew about ARDS, but we didn't know how to manage it. So these patients, if they developed, you know, severe shock or ARDS, they would just die. In the 90s, we started to have more developments in technology and in research, and we started to be able to keep sicker patients alive for longer. And we were playing around with ARDS, this acute respiratory distress syndrome, when there's an insult to the lung and the lung becomes inflamed and stiff, right? So the theory was with these stiff lungs, let's give high pressure and high volume. Let's really force those lungs to open up like they should. And so they were giving 12 milliliters per kilogram of lung volume or tidal volume to these patients, which is 2 and 3 times the volume that we give now. So if you can imagine, these lungs were popping. they were having pneumothoraces, right? And they were giving high pressure, and these were old ventilators that couldn't like sense the patient's breath and like synchronize with the breath or acclimate or give much feedback. So it was just pounding huge volume in and pulling it out. And these were stiff and endotracheal tubes. So these poor patients, there's no way they could just be awake and not fight what the ventilator was forcing them to do as far as breathing patterns. So we were like, well, what do we do? We got to make them stop breathing. So we brought up medications from the OR: benzodiazepines, barbiturates, opioids, paralytics. And we knew that during surgery, it was great, caused amnesia, don't remember a thing. So let's do the same thing up here in the ICU, not knowing the difference between a few hours versus a few days to a few weeks. And so we were giving like Ativan drips and just crazy stuff, not knowing what that would cause. And so the late 1990s, early 2000s, we looked back at how we were doing things, found out a lot of, not most ARDS patients died. And early into the early 2000s, we saw over time that those patients that did survive, though their lungs got better, they continue to have cognitive, psychological, and physical disabilities. And we couldn't figure it out because their lungs were better. We fixed the lung problem. So why aren't they back to their lives? And that during that time, in the 1990s, Polly Bailey, as I mentioned, my mentor there at that hospital in Salt Lake, had followed an ARDS survivor home. And she saw this mother in her early 30s struggle for a year to get up the stairs, and her husband had to help her with the bedpan. And she was so traumatized and so like cognitively destroyed. And Polly was like, I think we did this to her. But there was no research about it at the time, right?
Mm.
So she went to her medical director, Dr. Terry Clemmer, and he's on episode 2 of my podcast talking about how he recognizes he harmed patients during that time. And I love what he said because he's like, okay, Polly, well, what does the research show? She scoured everything. There was nothing. He's like, well, what do we do about it? She scoured everything. There was nothing. She's like, I think that we need to try to keep them awake and mobile, even when they're super sick. And he thought it was crazy. But he says, but I trusted nursing instinct, and I knew Polly would keep her patients safe. So I let her try. And so when they did, they immediately saw a contrast in outcomes. But it was a hard sell to get the rest of the nurses to now go against what they knew, because when you have someone sedated, they're not moving, their eyes are closed. And so the belief was that they were sleeping, that they were as comfortable as they looked, that we were protecting them from trauma, of the stress, of the reality of this tube and the lines and drains and critical illness. So that belief had spread like wildfire. And what nurse doesn't want to just have their patients sleep through a very traumatic, stressful experience? So it was hard to go against that. Even after a few years of this practice, it had already been um, cemented into the culture. And now here Polly was going against it without any research as a young female nurse.
Hmm.
And
Badass.
so bad. I know she was like,
Yeah.
she's just my hero, right? And but she was also very spiritually driven to be like, this is the right thing. And once you see it, you can't unsee it, right? So now she's like, I ethically have to do this for my patients and I have to like lead them. So it was hard to get, that was a shock trauma ICU. The hospital opened another ICU and they let Polly do the hiring and the training for that new ICU. And instead of hiring ICU nurses, she hired nurses from nursing homes who had no experience in the ICU, and she brainwashed them to think that this was normal
Nice.
and taught them all the other ICU stuff. But she's like, yeah, we just keep them awake and mobile. Now, initially, this was before step-down units really existed. So that ICU was kind of like the ventilator weaning unit. When patients were already kind of destroyed from the shock trauma ICU, they'd send them to Polly, and Polly would rehabilitate them. They would do all the hard work to get them cleared out of delirium, rehabilitated, mobilized so they could get off the ventilator. And they saw how well these patients did. Then some of the physicians were like, well, why don't we just send them straight to Polly from the ER? And they started doing that. And that's how it kind of became a respiratory ICU. And that's when Polly was like, well, if it's this hard to clean it up, what if we never cause it? And so let's just let them wake up right after intubation. And that's when they realized that is so much easier. And the nurses knew nothing else and they never wanted to go back. And so that's where, late 1990s, early 2000s, that's what they're doing. They published on that in 2007. I come into the scene in 2012. And by then, those nurses had been there for so long, they retained their nurses because they enjoyed working there. And I just knew nothing else. But that study in 2007 set off more studies. And we had, already had outcome studies of this post-ICU syndrome happening. They're like, oh, Polly can do it. And actually, Polly was booed off the stage at critical care conferences.
Get out of here.
Oh, I mean, it's like figuratively, like these
Yeah.
intensivists from all sorts of parts of the world, good old boys and their big egos. And I can say that Polly would probably never say that on air, but like, I wasn't there, but I do
You're
know, and
not
I've heard
naming
from,
names, you're making a
no,
generalization.
yep, it was the culture, that she was
Yeah.
female, she was a nurse, she's
Yeah.
presenting at big critical care conferences and even going to other countries and presenting, and they're like saying the same things. Those aren't sick patients. She's like, PF ratio of 89. We have data on their acuity. Oh, well, your patients are different, or that didn't really happen, or like they would just. So she just kept quiet for a long time. And so that's why I'm really passionate about telling her story because she won't. She's so humble, but I'm like, she inspired more people to try this. So you have a Schweikert trial that comes out in 2007, 2009, mobilizing patients within 72 hours after
I
intubation.
want to, what is that?
Yeah,
I want to put that
Schweikert.
link in the
Yeah, I'll
show
send you a
notes.
link.
Yeah, please do.
Yeah, it's hard
Okay.
to spell.
Yeah.
But that was a much larger study and showed that you decreased delirium by 2 days, time on the ventilator by over 2 days, and it was safe and feasible. And that's where Johns Hopkins, so like talking more about Polly, the bad A of nursing. There were a few people that listened to her at these conferences. So you have Dr. Wes Ely, Dr. Dale Needham. So Dr. Wes Ely is at Vanderbilt, Dr. Dale Needham at Johns Hopkins, and they were like, Polly, what are you doing over there? So they flew out to Salt Lake, went through her unit, and they were like, whoa. Dr. Wes Ely had been doing research on delirium and understanding how lethal it was and how harmful it was. And Polly's like, well, here's the solution. Let's not just complain about it. Let's do something about it. He sees that and he's like, well, Polly, come to Vanderbilt. And went around and said, take sedation off of that patient, that patient, and just showed him how to do it. Johns Hopkins as well. Dale Needham invited her to come up and she taught their nurses, just don't sedate them. It sounds so simple, but it's really not.
It makes me want to
When you,
stand up and cheer. I mean,
I
like
know.
it's so exciting. I'm sure a question that was and a lot of nurses with an ICU nursing brain, how do you, after they wake up, after they're
Yeah.
sedated, the initial, because the way I would always think about it, like if I have, if I inhale my saliva by, I have a massive coughing fit, and then you just like empathetically, oh my gosh, it must be so uncomfortable to have this hard plastic tube in, your trachea for that long. And of course, how do you train the patients how do you get them used to it where they can like have it jiggle and be awake and mobile and have that irritating hard plastic thing not cause coughing and gagging?
So if you're a nurse, what's the feeling you associate with going to the mailbox and seeing that notification that says your license is up for renewal in 90 days? Do you go, yes? Or, oh, right? Why? I mean, it's not like they're hard to get. You have 2 years and there's so much free stuff out there. And yet we drag ourselves across the finish line, kicking and screaming because they suck. They're boring and antiquated and the delivery mechanism is inconvenient. And the thing is, if you're a nurse, we love to learn. We're always listening to podcasts and audiobooks and YouTube videos because we're just curious. But we have to pick through this pile of crap so that we can remain a nurse. Well, we created RNegade.pro to change that. We wanted nurses to be able to get credit for the stuff that they're naturally inclined to do anyway. It starts with a podcast. And then we're creating courses, and we want everything we do to feel like what you're naturally doing. The research shows that that's how we learn and retain best. Check it out. Pick one. See what you think. So maybe when you go to the mailbox next time and get that notification, you'll have that, yes.
Yeah, and it's not just about not giving sedation, it's what we do instead. And
Yeah.
not like sedation's and never. I mean, we had patients on methamphetamine highs that were like levitating off the bed and trying to kick everyone. That's a good time to give some sedation. But do we now knock them down so far that they don't respond to voice? No, we just knock them down just low enough that we can send them out the side of the bed and help them work through that agitation, right? But for most patients, if we have a chance to prep them beforehand, that's a prime time to get things ready to say, looks like you're headed towards intubation. You're going to be awake after we put this breathing tube in. We're going to sedate you for the procedure because that's miserable. But when you wake up, you're also going to be miserable. You're going to be unable to talk. That's going to be scary. So how would you like to communicate? Pen and paper, cell phone? Okay, we're going to have that right there at your hip. You're also going to be tied down because it'd be so normal to just go for that tube until you are oriented to what's going on. And we know you're not going to pull that out. So don't worry. Our goal is to get you untied, but just so you know, you're going to be tied down. So you think about all the things that are going to cause panic. You're going to cough and gag, but you can get used to it. And that comes with experience. Like for me, I never questioned it because everyone treated that as normal. You walk around the unit, you see people sitting in the chairs hanging out. They're not like in absolute agony the entire time. So you set that standard, but you also don't lie. It's going to be absolutely uncomfortable. But like all these other patients, and maybe those patients have seen him. If they're sitting on a high flow for a while in the unit, if we have a chance, maybe they've seen patients walking around the halls. So having the whole team normalize it. Then the respiratory therapist is coming in saying, hey, here's your new best friend, the ventilator. Here's your endotracheal tube. This is what's going to be in your throat. It's going to be uncomfortable, but you and I are going to work together to make sure we change the settings on this ventilator to make it as comfortable as possible. During intubation, you can use viscous lidocaine for lubrication of the tube to have some topical numbing. You can do some fentanyl pushes after intubation to help with the air hunger, help with the local pain. I see that we have our patients at like 30 degrees a lot of the time. That is a recipe for lots of subglottic secretions. That increases the panic and the coughing. That increases the air hunger. So before they even open their eyes, you make sure you have them as high up as you can. Make sure you have their family members right there helping them calm down, holding their hand, communicate. So you do these things that are anticipating all those triggers of anxiety. But then, like, once the dust is settled, letting them sit up at the side of the bed, letting them walk to the chair, letting them get to the commode or the toilet, like doing normal things in a very abnormal situation does wonders for anxiety. But being strapped down to the bed, confused from all these drugs, something down your throat that you think is a snake or a knife, thinking that you're kidnapped, it all expounds it all exacerbates.
Yeah.
It all exacerbates the trauma they're having. So it's not just the tube. Whereas we need to create an environment in which we can minimize the environmental stressors and then help them preserve their coping mechanisms to be able to cope with the tube.
I literally was just looking at what I read at the beginning of this podcast that we were giggling about, and I'm trying to find it because the energy you project is the reality you will receive. You're changing. I have a little bit of chills because you're changing the patient's reality for what to expect, right? You're teaching them. They've never been through it before. Maybe they have, but probably most of them, it's a first time experience. So ahead of time, you're setting the stage for what to experience, and you're going to show them how to experience it in a totally different way.
You're kind of like their doula.
Yeah.
But that's not the role that nurses or any of the team is taught to play. And it's not just on nurses. That's really important as well. Now that I train teams to do this, I'm very passionate about making sure everyone is participating in this.
Yeah.
So it doesn't come all down to the nurses, because as of right now, and I experienced this as a travel nurse, those awakening trials are all down to the nurse. And when I did them, it was 5 a.m. So I'm in a dark room by myself. I'm turning off the pump. I don't know when they're going to emerge from sedation. I've got another patient in another room that I've got to check on. I've got labs to send. I've got so many things going on. So I do have to leave that room at some point. Or I might be in the room and they suddenly emerge and they're absolutely panicked and I'm by myself and I don't have any other tools besides the pump. So that's what we want to avoid, but that's what most nurses have to live with and endure, is patients coming out confused, agitated, trying to self-extubate. It's very stressful. And then we have a punitive environment in which if a patient self-extubates, that's all on the nurse. They're the worst nurse ever. So it's fun for me as a consultant now to work on the roots of a lot of these things to change the environment, not just for the patients, but for the nurses, where everyone is safe and working towards the best outcomes. And we're not penalizing people over stupid stuff. I mean, I have had an intensivist and an ICU that I trained say, listen, nurses, if you guys get a patient that self-extubates, I'll give you a Starbucks gift card. Because that means that they're awake and strong enough to pull that tube out and they're going to be safer than sedated with that tube in.
Yep.
So it's just a huge shift in culture for everybody. It's like telling them the world is flat. It's a really big deal.
I know, because the confirmation of that niggle, of that intuition that says, this isn't right, this isn't whatever, I wouldn't even need to witness an awake and walking ICU. I would just need to have somebody tell me the story, this hour-long podcast. It's like throwing kindling soaked in kerosene and just throwing a little spark on it. And I could see that just going, And I'm so curious if that's really what's happening, because it just makes so much sense. I wouldn't need to witness it to believe it. All I would need is your story and show me one research article, and I would never be able to go back to the doing the way. Is that what you're experiencing when you do these consultations and you go to these hospitals, or do you get a lot of resistance still?
It totally depends on the team, the culture, where they're at. Like some teams have had previous initiatives working on this. And so like they're like, I know we should be doing something like this, but we need help to actually make it happen. Other teams have no concept of this and they're like, no way. Sometimes the nurses are the instigators being like, we have to do this, get our whole team on board. Sometimes it's the nurses being like, we can't do this. So it just is so variable.
Mm.
There's a lot that does go into it. And I had oversimplified it in my mind working in that environment where they've done it for, almost 30 years
Yeah.
now, where everyone had the skill sets, they had the teamwork, a lot of the things that it just made it so efficient. But when teams first try to do this, they're so scared.
Mm.
They have 9 people in the room to get someone up out of the chair, and it takes 30 minutes. Those kind of things can really set them back to feel like, okay, Kaylee's full of crap. This is not feasible to do with everybody, but a lot of it depends on the timing as well. So throughout this history, right? So we've got early 2000s, we're like, ooh, we're causing damage. 2007, 2009, we're like, oh, this helps if we get patients up sooner and we mobilize them, and this is safe and feasible. We should be doing this. And so the ABCDF bundle is a group of cares. It's a bundle that was created to point care towards an awake and walking ICU. Like what goes into making this happen? Things
Mm.
like pain management, systematically turning sedation off when it's not needed, breathing trials to get them off the ventilator, choosing the right sedative if it is needed, delirium prevention, mobility, family, all these things that points towards that process of care. But it was rolled out. It's kind of like a checklist of things to document. And we as nurses, we are good at our checklists, right?
Yeah.
And so the thought was, okay, we'll just make people document these things and that make sure that they get done and it'll just happen instead of transforming the beliefs and the perceptions about how care should be. So these checklist items got twisted into perpetuating old practices. Does that make sense? So
Mhm.
like awakening trials should be right after intubation if there isn't an indication for sedation. But it was like, oh, we'll just do that when we're trying to
Yeah,
get
it's
them off
like
the
kind of like
ventilator.
a thank you for saying that, because now I feel bad. Oh, I would totally do that. You're right. You need the support, you need the environment that facilitates an awake and walking ICU. Otherwise, it's like asking someone to do a handbrake turn, in the fast lane in a 5-lane freeway going 80
And
bucks. No, you can't
And
do
we
that.
love a good
Yeah.
conveyor belt, right? And that's what we've loved about sedation and mobility is it's predictable. We're just going to sedate everyone. We don't have to think about it. Everyone's going to be comatose. Everyone's going to be strained. And no, there's no personalization needed. And so it's not that simple when you now take sedation off and now you're dealing with an individual that has individual needs, and it takes a lot of critical thinking, a lot of humanization, and not everyone's prepared for that. I mean, some of the questions I've received, I hadn't really thought about. For example, when I talk about letting them wake up after intubation, some of the questions I've gotten from nurses is, well, what do you say to them? How do you communicate with them? And it reminds me of, raising my kids when I try to give them a spoon when they're 18 months old or 12 months old or whatever. I'm like, oh, you don't know how to use a spoon. You're not just born knowing how to do that. Even though it seems so instinctive for me, I at some point had to learn that. I learned these skills by peer modeling. That's all I knew when I was born into an environment. Now you're trying to create this environment, and every clinician in the ICU deserves the opportunity to understand the why and be taught the how and to practice it in a safe way, and then to have the support to continue to carefully develop those team dynamics and care. So in my mind, I was like, in this podcast during COVID, right? I'm working in an awake and walking COVID unit. I'm also working telecritical care, and I'm overseeing COVID care throughout an entire region. And I'm like, wow, we are doing these things so differently. And in my mind, I just thought, do what we're doing. Just don't start sedation unless you have to. Get them up. And it really does simplify it when you do early on. But people are so scared. They don't know how to communicate with patients nonverbally. They don't know how to mobilize them. They don't know how to tell when it's safe and when it's not safe to mobilize them. Nurses, might have art respiratory therapists that are like, nope, not with my patient. That's my ventilator. That's my endotracheal tube. You don't get them up. So there's like power struggles, there are politics, dynamics. There's just so much going into it that over time, as I was doing these grand rounds presentations, people would reach out and say, hey, can you convince our team? Do a presentation. So I would, but I would just drop a truth bomb saying, you're harming people. Look at my case studies and my pictures and videos. Do it this way. Bye. And I think I caused some moral injury
Mm.
because people maybe thought it was so simple, but then they go to the bedside and they're like, where do we even start? So
Yeah.
then I started realizing they deserve more. They need more. And like, if I could just go to the bedside and show them how to do it, if they could just see it with their own patients, they'd be more bought in, but also they'd feel more comfortable to even try it. And
Yeah.
that's those first few times are so scary. We don't just like watch a YouTube video on central line placements and just go do it. You get thorough training on the anatomy, the risks, how to do this, X, Y, and Z. And then you have a mentor that's next to you as you start doing it. But we're treating this as something like we assume that people already know how to do it, and they don't. So it's not safe and it's not fair, and we'll never get there unless we have really proper training, which is why I started doing consulting because I realized that I was putting out all this podcast content. People were very excited and it was making changes, but now you have revolutionists scattered throughout the world that are pushing for changes, hitting constant barriers, constant walls, and they need more reinforcement to get the rest of their team to be as excited and bought in and prepared as they are.
Amazing.
Yeah,
Is it bring into like talk about a tough environment to change, but the schools, nursing schools, like changing the way it's done from the beginning?
great point, Wendy. Are you going into nursing schools?
Yeah.
Um,
Are you?
yeah,
Like,
I would be happy to. You know, it's been a lot of work just hitting the critical care side. There are really great initiatives, great innovations. Like I have a friend, Marie Pavini with HD Medical. She's created VR goggles that simulate the patient experience during sedation and
Oh,
delirium.
wow.
And I think those should be in every nursing school, RT school, medical school. Like there, so I love seeing other revolutionists coming up with more solutions because it's really I'm not the first one working on this, and I can't be the only one, right?
yeah,
So it's fun to see more people talking about it. More influencers, nursing influencers are talking about it because we're now changing the culture. I mean, I about like a year and a half ago, there's a whole social media campaign from a nurse influencer trying to get my license taken away, thinking that this was unproven, unsafe practices that I was advocating for. And so it's taken a while to really change the climate to make this welcoming to more people to talk about. It was like a really scary thing to talk about for a while, especially during COVID, because
right.
we were back in the 90s in our practices during COVID, and that's a hard thing to really call out.
I
Yeah.
was thinking during that time that it was probably COVID was so many nurses and doctors were doing things that they didn't believe in, that it was probably such a good time to shift consciousness to be like, oh my gosh, like in some ways it was probably the perfect time when you got done the podcast too, because so
Well, they
much.
could, yeah. And when I talk about the harm of these practices, that's what they were living all the time. So many of these patients couldn't get off the ventilator because they wouldn't wake up or because their respiratory muscles were so atrophied or
Mhm.
dysfunctional that they had to be trached, pegged, sent to LTAC. I mean, that was the conveyor belt, right, for COVID patients. Whereas in that awake and walking ICU, they were one of the high security COVID units in the state of Utah and probably like count on less than two hands how many patients end up with tracheostomies, and usually it was because they had comorbidities like interstitial lung disease or muscular dystrophy in addition to that. So um, I think when I talk about it now, those that were there during COVID, because we lost a lot of those by now, they didn't stay. It was so traumatizing. But why do you stick around to work so hard to see poor outcomes? So if they remember what we're talking about, I do try to use a little bit of an example. I try not to dwell on it too much, but to say, you saw this, but this is what we're going to work towards preventing, and this is what you're going to be able to see. You're going to be able to see patients be able to maintain the cognition and strength to write clearly to you on a clipboard. That's going to be so much easier. You're going to know what they need. You're going to be able to treat their needs. You're going to see them get extubated. You're going to be able to party with them, play music in the hallway while you're walking. And even during COVID, the first team I ever trained was in 2021. That was very intimidating because it was still thick of COVID. And I knew this was a huge ask to try something so new during such a hard time. And I remember standing in this group of clinicians and the respiratory therapists had their arms crossed and they're like, H no. We do not have the bandwidth for this. We cannot take on more. And I just had to ask them to bear with me and like give it a chance because if we decrease time on the ventilator, that's less ventilators you have to deal with. You're actually going to have fruits of your labors instead of just pushing buttons on zombies all the time. And when I went back 6 months later, the whole environment seemed different. I mean, the countenances on these clinicians was different. They were excited, they were happy. They wanted to pull us into the rooms to look at their patients that were sitting in the chair and awake. And those respiratory therapists were the biggest barriers, and they were then the biggest champions saying,
Yeah.
I have showered my intubated patients. They
That's
get extubated, they
awesome.
walk out the door like, this is so bad, eh? This is exactly why we got into this. This is so much easier. We're drastically decreasing time on the ventilator. We have less vents to manage. And when we do manage them, it's for something.
Kelly, I feel like what you're doing is a symptom of a pendulum going back the other way, where holistic medicine before the Flexner report and wasn't holistic. Whatever, you know what I mean. Before conventional medicine became conventional medicine, and the head was removed from the body, and then the body was separated in all its different systems and parts. And now that there's moved back to thinking of a person holistically, what goes on in your head. No, we're not saying that all your symptoms are in your head. We're saying what goes on in your head has a profound effect on your biology and the spiritual component coming into that. And it's like the human is being reintegrated. And you're not saying, okay, we're going to sedate you, intubate you, fix your lungs, and then new part, now you get to go to rehab and recover. And then new part, then you get to go. It's all being worked on integratively in a mind, body, spiritual, pathophysiological, pharmaceutical way. It's all being considered. And you are just a metaphor for that. And I also like that. I love how you speak about it as a vocation. I love that you say you had a calling, that you heard a voice, and that you say H no. I love that. I mean, it's
If I
no,
had, I mean,
it's
if I
the
had known how hard
whole,
it was, yeah,
yeah,
if
the
I'd known
whole
how hard it was
package.
going to be, like what all would go into this, I really thought I was just dropping some podcast episodes and clearing my conscience of it, washing my hands and walking away. And I couldn't have handled the big picture, what this would turn into, but I'm grateful for it.
Yeah, well,
But
isn't
yeah,
that the plan? Just enough to, what has Mother Teresa said? I know that God won't give me anything I can't handle, but sometimes I wish he didn't trust me so much. Just little bite-sized pieces, little prompting here, whatever, and you answered it. And I am so excited. I think that this is enough to just, I mean, listening to this podcast, if I put myself in somebody else's meat suit, it's just like I need a couple days to just digest what I just heard.
but it applies to, all sorts of specialties. I think
Yes.
nurses can and should be revolutionists, disruptors. Polly Bailey has saved millions of lives, and she probably has no real concept of that. Just thousands within her own ICU, but the impact that she's made throughout the years just by persevering and following that nursing instinct
Mm-hmm.
and leading research. It has changed so much, and we need that kind of innovation throughout all specialties of medicine.
Yeah, it's beautiful. And go ahead, Wendy.
No, I was going to ask a kind of back to the medications and stuff. When you look at delirium and the medications that were and are, depending on where you are in the country, for this, is there certain medications that had more effect than others in negative outcomes? Have you seen that in the research too?
Absolutely. So benzodiazepines is a class of medications, a class of sedatives that we really loved in the 90s. Ativan is the most dangerous. We know for every 1 milligram of Ativan, there's a 20% increased risk of delirium in the next 24 hours. The next top culprit is midazolam. That was really phasing out in the 2010s, and then COVID hit and it came right back because we had shortages of other sedatives. Um, we had a lot of toxicities anyways. So now in some ICUs, they still don't use it. Other ICUs, it's become normal again. But for every 1 milligram of midazolam, there's a 7 to 8% increased risk of delirium. So you give a 5 milligram dose per hour of this continuous midazolam, and boom, 24 hours, you've got an 840% risk of delirium. So not only increases the risk of it, but also the duration and severity. And for every 1 day of delirium, there's a 10% increased risk of death. So that's likely why we see increased risk of mortality with the use of benzodiazepines. But then the next top culprit is propofol, which has a lower risk than benzodiazepines, but it still carries a risk of delirium. It disrupts the brain activity so that, and so do benzodiazepines and opioids to a certain degree. It disrupts the brain activity so that the brain cannot get REM cycle 3 and 4. So these sedatives are actually the opposite of sleep. It causes sleep deprivation. And you look at victims of torture by sleep deprivation, they end up with brain injuries. They develop hallucinations, PTSD. They develop delirium. It's a brain injury with long-term repercussions. So patients that have delirium are at high risk of having long-term cognitive impairments similar to mild Alzheimer's and moderate traumatic brain injury. So I call it a sedation-induced brain injury. And so the longer they have it, the more cognitive impairments they're going to have, no matter how old they are. So regardless of age, you can send them on to live lives of mild Alzheimer's without it being progressive.
I just back to an experience with my mother in the hospital with cancer, and they gave her Ativan, and she literally went completely psychotic. And then they just put her out. She literally went completely psychotic on me, and I was like, "What the fuck is happening?"
Yeah, well, that's
and
a
then we
great.
don't know what to do with that, right? So we give these medications hoping that it'll calm their anxiety, help them sleep, but it causes acute brain failure. Then they come out with agitation, and then we respond to that agitation with more, we respond to that agitation with more sedation, which causes more delirium. And so the Ativan, I call it a roller coaster. It's terrible. And as from a nursing perspective, acute care floor, as well the ICU, ER, you give it, it knocks them out, makes them quote sleep. It's not sleep, but they're chemically restrained for a few hours. But when that wears off, they come out again, and it's another rodeo. They're a bucking bronco, right? So you run back to the Ativan, and so you have these as needed orders, but you end up giving it every
Around the clock, yeah.
4 to 6 hours, and over time, yeah. And we've done that with alcohol withdrawal for so long. It's miserable. So when I hear nurses say, "Oh, but we have so many alcoholics," I say, let me guess. You have an Ativan CWA protocol still. That's the first to go. That is so miserable for everyone involved. It keeps them in the ICU for so much longer, and they come out just so debilitated, so confused for so long. You don't know what is withdrawal or what is delirium. Let's just get over that. Now, I really advocate for phenobarbital protocols for alcohol withdrawal. So this impacts the entire healthcare system. And for someone that's older, they should never be receiving Ativan. That's like Beer's criteria
Yeah.
101. So I'm so sorry, Wendy, that happened to your mom.
Yeah, for
to
anyone
people.
listening, just like glossary of terms, the beers list, what is it? Anybody over 67 or 65? They're just the beers list is a list of medications that anybody over a certain age should absolutely not have under unless, there's very specific situations when nothing else is, because it almost can have the opposite effect. Not almost, it does often. Just the way the brain processes and the body metabolizes those medications, it does not work the same in elderly people. So anyone who is not a nurse and listening to this, it's a good thing. Actually, I think this podcast is not only great for nurses. Anybody can go over to RNegade.pro if you're a nurse, and you can take a simple question evaluation and get a CE for listening to this podcast. But any layperson who's a non-medical professional is going to be better equipped to advocate for their family members or for themselves. Is there a list of ICUs in the country that are wake and walking?
I'm working on it. Yeah, I've got a few on the map, and there are some more developing. There's a spectrum of accomplishment within this. Certainly the teams that I've trained, I recommend. I'm really proud of the progress that they've made. It shows up in their data and their costs, their length of stay, their outcomes. It's so exciting. And there are other teams that are doing great work. They are the exception still. I also have another podcast for families called Walking You Through the ICU. So those lay people, if that might be of interest, some of the later episodes, it's only 11 episodes long, but it gives a very simplified explanation of the problem and the solution. because I definitely feel like families should know about this. It's a little bit hard to navigate because you don't want to foster mistrust, or help make them feel like clinicians don't have the best of intentions. So that's what the podcast does, is kind of helps them navigate how to advocate for their loved ones if and when they're in the ICU.
And do you have new podcasts in your library? Or you just had like the 30 and the 11, and now it's consulting, and that's kind of like forms a basis of information for nurses and lay people. And then
My first podcast
what
for
are you doing these
clinicians.
days, Callie?
I know, so many things. The first podcast that I started with is walking home from the ICU, because that's the goal, that we help patients walk home or go back to however they were and wherever they came from. That now has 201 episodes.
Oh, okay.
That's on my podcast. That is on my website under the podcast tab, and there's a search bar. So you can look for topics. It's also categorized. If you want to listen to survivors of sedation and immobility, boom, they're all categorized. Survivors of awake and walk-in ICUs, you can listen to them. Nurses that have worked in awake and walk-in ICUs, you can. So there's a lot that goes into it, and I just can't stop learning about it. So I just keep learning and recording people teaching me stuff, and I've now interviewed survivors of the ICUs that I've trained, talking about what it was like to be awake and communicating during mechanical ventilation. And so, yeah, that's ongoing. I just feel like there's always more to explore. The family podcast only has 11 episodes. That's going to stay limited because there's only so much they can handle at that time.
Hmm.
Fabulous. Absolutely incredible.
Yeah, this 1 hour has been so rich, and now that they know where they can get more of case studies, not only from nurses who've done it, but patients who've, compare and contrast an awake and walking ICU versus what we're all used to. Very rich and fraught for rabbit holery.
Yes, buckle up.
Yeah. But we're so excited to have you. Thank you so much for your time today in this interview. And it's so important what you're doing. And God bless you. I mean, it's just amazing. I know you have your mentors, and I know you have your collabs. But you as an individual are pioneering massive change for anybody who has an open mind and open ears. And c'est moi.
Yeah.
So anything we can do to support you, please let us know, in addition to just getting information about you and your work out there.
Thank you so much. Thanks for supporting this revolution. There is an army, and we're always.
I love how you keep saying revolution, and you are spot on, girlfriend. Thank you.
Thank you. I feel like we can't fix what we can't.
Yeah, you're spitting pearls, so I'm just going to keep it rolling.
Well, I just love that you've done ICU, so you get it. You've lived it. I think you've suffered from it. I think nurses really suffer from this. I almost quit nursing during my travels because I was so burnt out. I just felt like I was working so hard and was having constant poor outcomes with my patients. And it felt like I was making a difference. And I remember one team that I trained, there was a nurse that had a patient, and this patient had just been intubated for ARDS overnight for aspiration pneumonia. And they were about to prone and paralyze him and sedate him. And we were like, oh, no, hold on, let's try this first. Let's get him up first. And they thought that was crazy, but that's what we were there for. So we were going in to do this. And then we realized that this nurse that had him had not listened to my webinars. So he didn't really know what was going on, what we were working towards, why we were there. And on top of that, he was a culture leader. There's certain nurses that if they want to do something, it gets done in the unit because everyone follows them. If they're not bought in, it's going to be impossible to move an initiative along. And so they're like, hey, this is a culture leader. He doesn't know what's going on. And I'm like, oh my gosh, this is not the patient, because the patient had high ventilator settings. I think he was on a PEEP of 16 and 90%. Oof. And so we mobilized this patient, and he was hard of hearing, but didn't want to use hearing amplifiers. He had sloppy handwriting, even though he had just been awake. It was hard to read his handwriting. And so he wanted the nurse to write out everything so he could read it, and then wanted to write out for the nurse to try to read his handwriting. And I was like, oh my gosh, this is the worst case scenario, because this is going to be such a tedious patient to take care of. And for someone to not know why they're doing this, quote, extra work, this is going to be disaster. This whole initiative is shot, right? So he spends all day with this patient. The next day we come into the Starbucks gift card, and we're like, hey, it's for keeping him awake. Sorry, that was really hard. He's like, yeah, that was the hardest shift I've ever had. And I was like, holding my breath. I kind of gasped, and he's like, but it was the most fulfilling shift I've ever had. I finally felt like I was doing something for a patient. I'm so bought in. I'm all in. Let's do this. And I was like, oh my gosh, that is the nursing heart right there. Like, yes. And really most patients are not as complicated or like needy as this patient was. He had a lot of trauma, like a lot of things going on, but this nurse, like it was worth it to him. So I never want to make people feel bad by talking about the reality of what we're doing to patients, but I also believe that you cannot fix what you can't confront. So that's why I'm willing to like put it out there, call it the problems, because I also know that there's a solution, that we're going to call it like it is, but it's to bring change, not just to wallow in what we've done or what could have been, but rather look forward in the future and actually bring change.
I love that you acknowledge the moral trauma. Like when I was CVICU, recovering hearts, and worked at Cleveland Clinic for a couple of years. And you feel like that, especially that first 24 hours, at least the first 4 to 8, you feel like you're doing the living for them. It's like a pressure for this, a back off for this. They're like on 10 different drips, and then and it's like, and you don't have like you volunteer for that. That's the kind of nursing I loved,
Yep.
like it's like rocket science, and then now knowing, after listening to this podcast, if I was still working in a CVICU, knowing that there's no other, like you can't unsee it, like you said,
Mhm.
the overwhelm of how, in addition to all of the stuff you have to do with a fresh heart, would you let them wake up after surgery, which is absolutely seems like what is the best thing for them.
Well, CVIC was actually now usually ahead of the game compared to other ICUs. So they're walking patients on ECMO, LVADs. They're sending patients with balloon pumps, Impellas. They're getting their post-op open hearts in their cabbage patients up within 4 hours after surgery. I mean, they're doing amazing things, but some ICUs are nowhere near there. So there's a huge spectrum. But I think that's an interesting population that there's a lot of financial tracking, so they're very motivated to get these patients up and out as soon as possible, but it's also to the patient's benefit. But there are times, obviously, if they're in severe cardiogenic shock and any kind of movement makes them completely unstable, you're stuck. You have to sedate them, and you will probably have to sedate them with some benzodiazepines. So there are times when it's unavoidable, but unless we know the risks of these interventions, we can't do a proper risk versus benefit analysis. And I love what one intensivist said. He said, all of these things are life support. We're supporting life, but life is not laying there comatose. That's not life. That's not the life we want to support. So it's really flipped the way I see what the role of these interventions really are in the ICU. For example, in the past, vasopressors were a contraindication to mobility. Now, especially in a CVE ICU, they'll increase the vasopressors and increase the inotropes to facilitate mobility. Ventilators were perceived as a contraindication to mobility. Now we increase the support on the ventilator to help them walk. It's like going from 4 to 6 liters nasal cannula. We're like, we're just going to pump up some more pressure support, pump the PEEP up a little bit to help them walk, just like a walker would. We're facilitating mobility. So we're using the science and the research that we've gained along the way to support real life, like actual living, and set them up to live lives worth living.
Can't think of a better illustration of a paradigm shift than that. Amazing. Okay, well, I'm glad I hit record again for this bonus material.
I was like, well, while you're recording, I'll drop more thoughts. I don't know.
No, I would love to do another one and go like in depth into like as an addendum to this, whenever you have time, like a case studies, like.
Oh yeah, I've got them. And if you look at my LinkedIn,
maybe I'll listen to some more of your podcasts and like have an expansion on some of those, or I don't know, but one is not enough. That's for sure.
No, totally. Yeah, on my LinkedIn, I've been just posting a lot of case studies, and I kind of put it into a graph where I compare it to other studies. So looking at that had different like levels of mobility or timing compared to an awake and walking approach. So you see different like levels of compliance with the ABCDF bundle and their outcomes.
Oh, cool.
And they're real case studies. So like this patient was awake and walking, but if they hadn't been, here's what I speculate would have happened if we'd waited 6 days or whatever. So
yeah, there's another reason why I'm glad I hit record. If somebody wants to get a hold of you, have you consult on their on their floor unit, hospital, whatever, it's Kali Dayton consulting.com.
Just Dayton ICU consulting.com.
Sorry, totally got that wrong. I just want to see if you knew it.
usually. But yeah, you can Google it, find my podcast. It's should be pretty accessible and all over.
Dayton ICU Consulting. You have lots of free research materials and links on there, links to your podcast, and everything like that. Your website alone is a wealth of information, and there's plenty of ways to contact you on there. So I encourage any nurse listening to this who wants to transform, be part of the revolution, go to Kali's website, listen to her podcasts, and buckle up. Thanks, everybody. Bye again.
Renegades.